So we're going to talk about ways that the body can compensate for um, for heart failure, for reducing cardiac output from the left ventricle. Because the body will easily, so the baroreceptors will definitely pick up on the fact that the blood pressure is lower, cardiac output is diminishing. So they're going to activate anything they can. The body is going to activate all systems to maintain cardiac output. And why is that? Is because the the brain is number one. And what does the brain need to survive? It needs a normal cardiac output, because a normal cardiac output is what gives you a proper blood pressure to maintain oxygen and nutrients such as glucose to the brain. So basically, the different systems we're going to talk about are going to force the heart to work harder in order to maintain normal cardiac output for as long as possible, even if in the end it harms the heart, because it wants that cardiac output to stay normal. So the first system that's going to, or one of the systems that's going to be activated very quickly when the body senses a reduced cardiac output from the heart, which is what happens in heart failure, is the sympathetic nervous system. So the sympathetic nervous system is going to do everything it wants, everything it can to keep that blood pressure up. So it's going to release epinephrine and norepinephrine to increase heart contractility, so the force of contraction of the heart per beat. It's also going to increase heart rate, and it's going to vasoconstrict all the non-important organs in the body. So there's going to be vasoconstriction of the arteries to the gut, to your intestines. There's going to be vasoconstriction of the arteries to the kidneys. There's going to be vasoconstriction to the skin. So all these systems are going to be sacrificed so that blood pressure and cardiac or blood pressure is maintained for the brain and for the heart, the coronary arteries, right? Because those are the two most important systems that without the heart, you don't have a brain. And without the brain, you can't function. So as cardiac output and blood pressure diminish, all the other parts of the body will be sacrificed to maintain those two organs with a proper blood pressure and, as much as possible, a proper cardiac output. So you can imagine that increasing contractility of the heart, increasing heart rate, is not a great thing for someone who has heart failure. It's not good. It's making the heart work much harder for a long time. So in the short term, it's going to maintain cardiac output and blood pressure, but in the long run, it's going to harm the heart, because in a way it's whipping it harder and harder to work, even though it's failing. So what's another system that the body is stimulating when it senses heart failure and reduced cardiac output? Well, the renin-angiotensin-aldosterone system. And what's this system going to do? So this is a system that is activated by sensing reduced flow to the kidneys. Well, that happens in heart failure, which then releases renin into the circulation. Renin converts angiotensinogen to angiotensin 1, and then an angiotensin converting enzyme converts it to angiotensin 2, which is typically in the lungs, by the way. This process from angiotensin 1 to angiotensin 2 takes place in the blood vessels of the lungs. And angiotensin 2 is a very powerful vasoconstrictor, so it's going to vasoconstrict the arteries and arterioles all around the body to maintain blood pressure. And it's also going to stimulate the adrenal cortex to release aldosterone, which will reabsorb more salt and more water. Okay, so the idea of all this is to maintain blood pressure and circulating volume. And in the short term, this is great. That's what the body wants, to maintain circulation to the coronary arteries and to the cerebral arteries to the brain. In the long term, it's not good. The heart is going to have to pump with higher volumes, higher salt content, and a higher blood pressure, because the angiotensin 2 is constantly trying to vasoconstrict the arterioles in the systemic circulation. So the heart is having to pump against a higher pressure. So it's competing interests, right? These symptoms, their goal is to maintain blood pressure and cardiac output. But what it's going to do, as the heart is failing already, is it's making the heart work harder. So you can imagine we have medications for all these groups to try and stop them from working, from blocking them. So we want to block these systems so that in the long run, we're not constantly making the heart work harder. Okay, and the third system that wants to keep blood volume at a good level is ADH. So if you have reduced cardiac output to the brain, this will be sensed. Well, let's do the first PowerPoint here. Low cardiac output causes neurological symptoms of confusion, dizziness, and fatigue. This low perfusion state is sensed by receptors in the brain. Okay, so on a previous slide, we saw that left ventricular heart failure does lead to confusion and dizziness and fatigue, and it's all about just a reduced overall perfusion of the brain and a lowering blood pressure to feed the brain. So you're going to get those symptoms. ADH senses this reduced flow to the brain, the pituitary gland senses this low perfusion state and releases antidiuretic hormone, which is going to be released into the bloodstream. And ADH will work on the renal tubules to reabsorb more water. And why does it want to do that? Because it wants to increase blood volume to maintain perfusion to the brain. Is this great for the heart, though, in the long term, to be pumping with higher blood volumes? Definitely not. Right? The higher blood volumes are potentially going to cause higher blood pressure, which the heart now has to pump against. The higher blood volumes can lead to backup of fluid from an already weak left ventricle. So you may go into pulmonary congestion and pulmonary edema. So these three systems are really interested in maintaining blood pressure and cardiac output. They're not really worried about the heart in 1 to 2 years from now, which is going to completely fail, because these systems are making it work even harder. So let's look at the questions below. 3 different mechanisms used by the body to attempt. No, that's not a question. That's just those are the 3 systems. right? The autonomic nervous system, the renin-angiotensin-aldosterone system, and ADH, antidiuretic. Those are all released in efforts to maintain blood pressure. And at the bottom, I've put as a reminder, all of these have the intention of keeping normal blood pressure and cardiac output at all cost. And the cost will be increasing heart failure in the long run. Okay, heart failure compensatory consequences. So we've already spoken about the three systems that are going to be stimulated to maintain cardiac output and blood pressure in the setting of a failing heart. And in the short term, it's a great idea. In the days to months that you develop heart failure, these systems will keep your blood pressure and cardiac output up as high as possible. In the long term, this chronic stimulation of the sympathetic system that's going to make your heart beat faster and harder, and the RAS system that causes vasoconstriction of the arterioles that can lead to hypertension that the poor left ventricle has to beat against, plus aldosterone secretion that causes increased blood volume, is detrimental to the heart in the long run. And then you add the ADH system that increases water reabsorption. And these three systems will stress the heart even further, which is then going to accelerate heart failure sooner. So we look at these three systems, and medications have been found to address two of these systems, the sympathetic system to block it, so beta blockers and alpha blockers of the sympathetic system. And the RAS system, we have ACE inhibitors, and we have ARBs, angiotensin receptor blockers. And it makes sense of why we're blocking these two systems, to try and delay the long-term consequences of chronic stimulation. So let's just talk about cardiac slash myocardial, which is really the cardiac is heart, myocardial is the muscle of the heart, hypertrophy, so thickening of the heart muscle. So the heart muscle, the myocardium, just like any other muscle that if you were to use regularly will thicken and get stronger, the heart does the same thing. So when there's heart failure in, say, the left ventricle, the heart recognizes the fact that the cardiac output has reduced, and is going to thicken the remaining muscle to try and maintain cardiac output. So initially you get left ventricular hypertrophy. So the left ventricle is weakening, the remaining muscle responds by getting thicker and trying to get stronger. And this happens as a heart failure compensation mechanism, this thickening heart and left ventricular hypertrophy. Now, what does it result in? Well, poor contractility of the weak, thickened muscle. So the heart tried to thicken its muscle, but the heart's gradually failing anyways. So it tried to get more layers of muscle. It tried to make it contract harder. But it's just not able to maintain cardiac output. So the contractility of the thickened muscle is poor. Now the thickened muscle, the hypertrophied muscle, also needs more oxygen. There's more muscle there. It needs more oxygen to try and contract. The blood flow has to get through a thicker muscle to feed all parts of it. So there's poor coronary artery circulation through all this thick muscle. And the thick muscle has all these nerves weaved in it abnormally, because it really shouldn't be this thick. So you're at risk for abnormal cardiac arrhythmias or dysrhythmias. They mean the same term. They mean the same thing. Arrhythmias and dysrhythmias, same word. So ventricular arrhythmias can happen from this abnormally thick muscle. So even though you might think, wow, it's great, I have thicker muscle, that's going to do the job. Typically not, because the muscle, even though it's thicker, it's still a weak muscle that needs more oxygen, that has poor circulation of coronary vessels through it, and poor development of nerves in it as well. So you're at risk for arrhythmias. So left ventricular hypertrophy is the response of the left ventricle to a failing left ventricle, to heart failure. So it tries to respond by getting thicker. So we've spoken about compensatory mechanisms that keep blood pressure and cardiac output up for as long as possible during heart failure, during those years that you have declining heart function, which is heart failure. There's another process that also happens, is that if those systems create too much volume overload, like say for example one day, you already have heart failure by the way, one day you decide to drink 3 liters of water, and you drink a whole bunch of, or you eat a whole bunch of chips as well, salty chips. Well, that's going to increase your circulating blood volume, which is going to be a definite stress on a failing heart. And there's a very high chance that especially if it's your left ventricle, that blood is going to back up and cause pulmonary congestion and all the symptoms of pulmonary congestion: short of breath, orthopnea, paroxysmal nocturnal dyspnea, coughing up blood, which is called hemoptysis, and this is all because of backup of blood into the lungs. There's a process that happens in the heart where there's what's called stretch receptors in the chambers of the heart, in the atrial chambers and the ventricular chambers. And if you can imagine, when you have more circulating volume, the chambers get stretched more. So the atrial chambers can release this little protein or peptide called ANP, and the ventricles can release a little protein or peptide called BNP. And they get released by the stretch, the increased stretch in the chambers involved. So you can imagine that when you get backup of blood from the ventricles to the atria, the ventricles are getting stretched because they can't take all this volume. The atrium is getting stretched because the blood's backing up into it. So you get release of these hormones or these peptides, and they are natural diuretics. They go to the kidney and they signal to the kidney that there's just too much volume in the circulation, in the circulatory system, and they are natural diuretics. So ANP and BNP cause a natural diuresis or a natriuresis. And this all happens without any drug given or anything. This is just how the heart can respond to more blood volume by saying, okay, enough. I can't take all this volume. I'm going to release these peptides to reduce my blood volume, since they act as a diuretic. Okay, and the one that we tend to use as a blood test is BNP. So if someone's in heart failure, we can, if we're thinking of that as a diagnosis, we can send off blood tests such as BNP to see if it's elevated in the bloodstream. And if it is elevated in the bloodstream, that's a strong signal that heart failure is part of what's going on in the patient in front of us. So, not that we don't have enough symptoms and signs to find as well, but BNP is often a confirmation of what our suspicions are showing us, that there is heart failure, because BNP has been released in the setting of the heart failure due to all the stretch that's happening in the ventricular chamber. Okay, general approach and treatment for heart failure. So if you can imagine someone coming in gasping for air because they have backup of fluid from their left ventricle into their lungs, they have left ventricular failure. So they're gasping for air, they're short of breath, they're frightened, they're pale, they're sweaty. What are we going to do? So there is a mnemonic here. I don't think you need to memorize the mnemonic. A lot of this will make sense. So you're not going to keep them lying flat in bed. You're going to get them bolt upright, right? You're going to get that bed right upright so that lowers the diaphragms and it can help them expand these very wet, congested lungs. So that's the first thing we would do, upright position. We use drugs coming up here. So definitely we're gonna give them nitrates. So nitrates in the form of nitroglycerin are vasodilators. So they're going to vasodilate the arteries and reduce blood pressure. That's great. That's going to lessen the work for the left ventricle to pump blood out. So it'll move blood forward. It'll also, nitrates will also dilate the veins. Well, that's great too, because that's going to reduce all this blood that's pouring back into the right atrium and right ventricle. So it vasodilates the veins and it vasodilates the arteries. So it reduces the preload coming back to the heart. All this blood that's coming back to the heart is not coming back as fast anymore because the veins have been vasodilated so they can hold more blood in the periphery. And on the other side, the arteries have been vasodilated so the blood pressures come down. Okay. Furosemide, Lasix, that will take fluid, that will diurese fluid at the kidneys and take some of the circulating blood volume. It'll reduce the circulating blood volume since it's diuresing fluid off. Oxygen, these people are often hypoxic, so they need oxygen. ACE inhibitors, what do? Well, they lower afterload, which is blood pressure, right? So your systolic or diastolic blood pressure, ACE inhibitors lower that by blocking, by reducing angiotensin II production. So they're commonly used, and ARBs as well in that group. Digoxin isn't used very much anymore. When it was used, we felt that it could help the left ventricle with its pumping. The strength of its contractility could be increased with digoxin. We've realized that that's not really the case anymore, so we don't use as much of it as we used to. Okay, what about the next? But we will discuss digoxin in other settings where we do use it sometimes. Not very frequently, though. Fluids. Well, we decrease fluids. So we're not going to give them a lot of oral fluids or intravenous fluids. The afterload. Well, the afterload's been reduced by nitrates, by ACE inhibitors. We may use other antihypertensives to reduce afterload, which is your blood pressure, right? Afterload equals blood pressure. So we want to reduce blood pressure or afterload to make it easier for the left ventricle to pump. We're going to put them on a salt-restricted diet and typically a fluid-restricted diet too. We often put people on 1.5 liters of fluid per day and a very strict sodium amount, so that they're getting foods with very low sodium content, and we're watching all of their fluids and typically restricting them depending on how bad their heart failure is in terms of the amount of fluid they get in a 24-hour period. And then testing, yeah, if they're on digoxin, that is a blood test that we can test for. We monitor the levels. That's partly why we don't use digoxin very much anymore, because the levels need to be followed. It can get very elevated with dehydration or renal failure, and that can cause a lot of harm to a patient. So sure, we can, if we're using digoxin, we can check the levels. Arterial blood gases, that gives us information on their pH, the oxygen status in their blood. K+, so potassium level, sure, we keep an eye on that, especially if people are on ACE inhibitors, since they can elevate potassium level. We keep an eye on potassium as well because of furosemide, which is Lasix, because that diuretics drain your potassium level. And definitely in the setting of someone who's taking digoxin, and remember this because I've seen this all over the place, digoxin and low potassium don't get along. So hypokalemia and digoxin magnifies the digoxin effect. So let me say that again. If someone is on digoxin, you should be looking in the answers, whether it's ATI or NCLEX or whatever, you should be looking for something that lowers the potassium level. And it's usually a diuretic, okay? Because hypokalemia magnifies the digoxin effect on the body, which can be dangerous.
Okay, so here's a question. What respiratory symptoms will you likely observe in a patient with left-sided heart failure? Well, if someone has decompensated left-sided heart failure, which really means left ventricular failure, we're almost always talking about the left ventricle or the right ventricle when we're talking about heart failure, not the atria. So left-sided heart failure is going to lead to a backup of blood into the left atrium, which is going to lead to a backup of blood into the pulmonary veins, which will then distend all the veins in the lungs. And that's going to cause leakage of fluid out of the blood vessels between the blood vessels and the alveoli, and that's going to be called pulmonary edema, right? So when you have pulmonary edema, you have fluid between the alveoli and the capillaries, making diffusion of oxygen into your blood very difficult. So patients become hypoxemic. And it also makes diffusion of CO2 from the blood vessels into the alveoli very difficult, and you can retain carbon dioxide in your bloodstream, and you can become acidotic from that. Okay, so what symptoms? Well, shortness of breath, difficulty walking upstairs, difficulty sleeping at night when you're lying down. So that's called paroxysmal nocturnal dyspnea, right? You can be so short of breath and so filled with fluid that you're starting to cough up a bit of blood because the little capillaries are starting to break open. So you can have some hemoptysis. But usually people come in saying, I'm really short of breath, I can't exert myself anymore, I can't go upstairs, I can't lie down at night, and that's all from fluid in the lungs from the backup. Okay, so this next question, how does isolated right heart failure impact respirations? Well, if the right heart failure isn't due to left heart failure, which is by far the most common cause of right heart failure, then it really won't impact the lungs at all, because the lungs are really after the right ventricle. So if the right side of the heart isn't able to pump blood to the lungs, well, they're not going to fill with fluid. You're typically not going to be terribly short of breath. So what are the main symptoms going to be? Well, they're going to be from the backup of blood that's trying to get back to the right atrium. And that's going to be peripheral edema in your legs, elevated jugular venous pressures, so distended neck veins. It's going to be an enlarged liver, which will give you right upper quadrant discomfort. And often you have nausea, loss of appetite, because the blood really can't get back to the liver from the intestines. So you often feel very lousy because of that, right? So gastrointestinal symptoms because of the blood backup, swollen legs, distended neck veins. But it won't impact respirations because it hasn't pumped to the heart yet. So the heart is not filled with fluid. Okay, so I always like talking about these mechanisms that the body has to maintain blood pressure and cardiac output. So what do you need to have a blood pressure? Well, you need a pumping heart and you need circulating volume of blood. You need both of those, right? So what is going to maintain cardiac output and blood pressure? Well, it's going to be your renin, angiotensin aldosterone system. It's going to be your ADH system, and it's going to be your autonomic nervous system, in particular your sympathetic branch of the autonomic nervous system, which is going to help with increasing contractility of the heart, increasing the heart rate, and vasoconstricting the arterioles to keep the blood pressure up. Okay, so think of the first two, the aldosterone and angiotensin 2 system, as reabsorbing sodium and fluid to maintain plasma volume. That's great. The ADH reabsorbs water to maintain plasma volume. That's great as well. And the sympathetic nervous system stimulates the heart to beat faster and harder, and also vasoconstricts the arterioles, all with the plan of maintaining blood pressure.